So good afternoon all, I'm Dr. JYOTI MATALIA and I'm going to be talking on disc edema. We just heard how to evaluate a cupped disc. Now let's see what happens when the disc is elevated. Now two important questions. When you see a swollen disc, you need to first rule out whether it's physiological and most importantly whether it's life or visual threatening. And hence every disc should be documented, monitored and followed up. So how would you evaluate? Yes, disc edema, look if there's a visual loss. If none, then we are looking at a pseudo or early papilloedema of the disc, diabetic papillopathy or a CRVO. So let's look at this patient who came with vision of 6/6, normal pupils, and you see a disc like this. So is this edema? Let's understand and evaluate the disc. Elevation is confined to it. Disc vasculature is visible at the margins, no venous congestion, sharp peripapillary nerve fiber layer reflex, and concentric circumpapillary light reflex with no exudates. So this is pseudoedema. And what you need to do, a B scan, which will show this calcific area, confirmed on CT scan. Also, if you have an autofluorescence, will show these calcific deposits, and this disc edema is actually disc drusen. So we confirm that this is a pseudopapilloedema. Then what is a true disc edema? Elevation extending into the peripapillary retina as shown, graying and mudding of the peripapillary nerve fiber layer, and obscuration of the vessels at the disc. This is true disc edema. So when you have something like this, let's look at chronic papillopathy. It's seen in patients with IDDM or NIDDM. Classically, vision be about 6/15, but no NVDs. There is edema. The best part is vision comes back to normal, and hence, over time, you come to know that this is a diabetic papillopathy. Classical CRVO will you see, but you will have other features of retinal as seen here. You need to evaluate and treat the cause of thrombosis and long-term risk of neovascular glaucoma, which is important. Now let's go to the next aspect. If you have a disc edema with acute visual loss, we are looking at major options of optic neuritis, ischemic optic neuropathy, and Leber's hereditary optic neuropathy. So let's look at this case. 15-year-old girl from Bangalore presented with 3 days duration, sudden onset pain in the left eye, associated pain on eye movement, very, very important, with decreased left eye vision, no history of any recent fever or complaints in the past. Ocular examination showed decreased vision, abnormal color vision and contrast, and RAPD, which is relative afferent pupillary defect. Very, very important. That's a pathognomic of an optic nerve problem. Look, as you switch the light from the right eye to the left eye, the pupil appears to dilate. That's because of the decreased pupillomotor impulse due to an optic neuritis in this case. Now you look at the disc, right eye is perfectly normal with a normal field, but if you look at the left eye, there is mudding around the nerve fiber layer around the optic disc. The nerve fiber layer you can see here, it's affected. So this, with a field test showing an inferior altitudinal defect, classically telling you there's a left eye disc edema. So in a young female with sudden onset of loss of vision, pain on eye movements, classical of optic neuritis, loss of contrast color, because first is the contrast to get affected, then the color vision, RAPD, and an inferior altitudinal defect, we are actually looking at optic neuritis. So this is very, very classical. When you look at loss of color vision, they will tell you the color saturation has gone down. So a red will look less red than what you normally see. Again, RAPD, very, very important. If you pick up an RAPD in a normal looking disc, you know it's an optic nerve. You need to evaluate from neuro-ophthalm. So this is left eye optic neuritis. When you get, how do you diagnose? A very, very thorough history and an appropriate examination. So what is neuritis? Inflammation of the optic nerve head, mostly associated with multiple sclerosis, but in Indian scenario, look for syphilis, sarcoid, TB, etc. also to be seen, which is important. So after this, when you are suspecting optic neuritis, look at MR imaging of the brain with contrast. That's important. Like this is the T2 weighted image. You will see the contrast enhancement happening on the optic nerve heads, which is classical. And the T2 flare image, you will see this ovoid, periventricular, perpendicular to ventricles, these classical lesions, which tell you that this could be related to MS. These are hyperintense lesions. So how would you investigate? Baseline MRI scan. If normal, just sequential follow-up. But if there are presence of 2 typical white matter lesions or more, we have to treat with IVMP. Now, IVMP is on the basis of ONTD trial, but remember, this is only to fasten the recovery. It does not do anything to the outcome. Even if you don't give it, eventually the patient is going to recover, but it will do it faster. And if you have this particular criteria, you are suggesting it of MS. There are other tests to rule out the other causes. LP has no benefit unless you're looking for papilloedema, where you look for the opening pressure to diagnose IIH. And for ischemia, look at other risk factors. So if you see, this is the classical defects, which are the ovoid lesions seen perpendicular to the ventricle, called as Dawson's finger. So this child had demyelinating optic neuritis with multiple sclerosis. Now you could also have demyelinating optic neuritis simultaneously or sequentially. If you have something like this, where patient comes to you in time of edema, it's fine. But what if the optic atrophy is already set in? So you have an optic atrophy in one eye, and the other eye shows a disc edema. You are looking at two types of demyelinating optic neuritis. One is neuromyelitis optica or NMO. The other is MOG IgG-associated disorder. So what is the difference? The NMO is a bilateral, simultaneous, or sequential relapsing optic neuritis with affection of more than 3 segments, that is of the transverse myelitis, as you can see here. It is classically associated with refractory hiccups and vomiting, and alpha-chlorine 4 antibody marker is very, very positive. You need to treat with IV corticosteroids and rituximab, but remember the recovery is poor. Unlike MOG IgG, this we have initially called as chronic relapsing inflammatory optic neuritis, bilaterally simultaneous peripapillary hemorrhage, but interestingly on MRI, the perinumeral and the peribulbar fat enhancement is seen. The MOG IgG cell-based assay is positive, and treatment remains the same, but excellent recovery. They do well, but you have to slowly taper the steroids because they are directly related to the steroid dose. Then how do you differentiate the next cause of acute visual loss? Ischemic optic neuropathy versus optic neuritis. So let's look at it. Ischemia occurs in older age, whereas demyelinating in younger. You have classical pale disc in ischemia. You would have sectoral disc edema as shown here. The superior part is paler than inferiorly. And you will have hemorrhages which are seen in ischemic cause. Association, therefore, in ischemia is vascular disease, whereas demyelinating is multiple sclerosis. And treatment-wise is excellent with demyelinating. So let's look at this case, a 60-year-old known case of diabetes for 15 years, painless loss of central vision. You can see right eye vision is less and has right eye RAPD. So now, as I said, you have a sectoral edema. See this? This is affected. At that time, what is important is looking at the other eye. Other eye, if you see the disc, there is hardly any cup. When you have something like this, there's an increased risk that this eye also will develop a NAION. So this first diagnosis is NAION, that is non-arteritic ischemic optic neuropathy with sectoral pallor and left eye disc at risk. So this is classical disc at risk. Watch this patient because this patient can have a problem in the other eye and treat the ischemic risk factors. And this case, as you said, the sectoral pallor is directly associated with the inferior altitudinal defect. So when I say disc at risk, what ischemic risk factors you treat? First, BP, check every patient with a disc edema in your OPD while checking the blood pressure and creatinine, because hypertension is in more than 34 to 50%. You have to do diabetic workup, CBCSR, CRP for anemia, lipid profile for hypercholesterolemia, serum homocysteine in young patients, look at other prothrombotic factors. Carotid Doppler is a must for IHD and thromboembolic phenomena. So now going to the third part of the disc edema, insidious visual loss, which would be compressive optic neuropathy or infiltrative. When we see compressive, we're looking at optic nerve sheath hemangioma, and these classical optociliary shunts is what you see. If you see them, you can expect a lesion behind, or an intraconal tumor. And classically, other conditions like leukemia and lymphoma, where you will have sudden onset, so a good history about his past will tell you what the problem is. Now let's come to the next aspect, bilateral disc edema. Now when you see a disc like this, we are worried, is this papilloedema or is it a bilateral optic neuropathy? And what we can differentiate by doing a vision loss, which is very important. So bilateral disc edema, no vision loss. Yes, we've seen pseudo disc edema, but you could also have early papilloedema, hypertensive retinopathy, and hyperviscosity. On the other hand, let's see, this is a patient with early papilloedema. Vision was perfectly okay, but you can see this indistinct elevation seen all around the optic nerve head. Our hypertensive retinopathy, you can see classical history of hypertension, narrowing at vessels. But malignant hypertension, if you see with grade 4, you will have this classical disc edema. Hence, every patient of disc edema, measure the BP in your OPD, important. Then, coming to the next aspect, visual loss in bilateral disc edema. These are multiple, few I've already described, but I'll talk primarily on papilloedema and inflammatory causes. So what is papilloedema? A patient with 34-year-old obese, transient visual obscuration is a very, very important history that you take. Other history is tinnitus. If they have these, you are going to think in terms of papilloedema. Vision, as you say, in initial stages is perfectly okay. So you just see hyperemia of the disc, elevation is indistinct and absence of the cup, and the other venous engorgement. So this is established papilloedema. Now this differentiates you from an optic neuritis where vision is lost. So vision in papilloedema is lost only in the final stages. This patient had an idiopathic intracranial hypertension. Initially, the fields are perfectly okay, but you start seeing the inferonasal step. This is the early sign of glacial constriction can happen. Now, as you said previously, I showed USG B scan is very important because it not only rules out a pseudo disc edema by looking at the drusen, but it classically picks up this crescent if you see around the disc. This is the SAF, the subarachnoid fluid of the raised ICP, which is transmitted around the optic nerve, which will tell you. And if it's more than 3.5 millimeters, definitely this disc is edematous. And why? Because you know that as the CSF is produced by the lateral ventricles, third ventricle and fourth ventricle goes in the subarachnoid space, and this space is right around your optic nerve head, and this is what you pick up in your B scan. Then comes the chronic papilloedema. You see disc is highly elevated. You see the optociliary shunts are also seen, and there are deposits like corpora amylacea, which are seen along with Patton's lines. So this is again the same sign. This is indicating of chronic papilloedema. Now the inferonasal step is gradually going into constriction, and the patient is started to lose vision. In atrophic, if you see, the disc starts appearing to flatten. You will see pallor setting in as seen here, and the Patton's lines. Don't get misjudged that the disc is flattening. Actually, it's failing. The patient has started to lose vision, and if you look at the visual fields, eventually it's going into complete constriction, and he will eventually go blind. So at this stage, it's important to treat. So how do you go about? Basically, investigate. You do the B scan to confirm there is SAF. That is a cause, and so you can treat accordingly. Imaging of OCT to know how much it's progressed. Visual fields. Non-ocular, record the BP, neurological evaluation and neuroimaging. CSF opening pressure will tell you whether this patient has papilloedema. Anything more than 250 millimeters water will definitely tell you this is papilloedema and you need to treat. You have to collaborate with a neurologist and they will treat accordingly. So how do you treat these patients? You would treat them medically or surgically. First, address the cause. If there's any tumor in the brain, you need to remove it because of any SOL. Then refer to the neurologist. What will be the medical treatment in IIH? That's idiopathic intracranial hypertension, oral acetozolamides, salt-restricted diet, and weight loss. Weight loss of 15% is a must. In COVID pandemic, we've seen being at home, people have increased weight over 3 months and have developed IIH. It has increased a lot. CVTs, cerebral venous sinus thrombosis. Identify the precipitating factors and treat with oral anticoagulants. Surgically, yes, reserved for conditions like if there's a mass or hemorrhage, you need to do neurosurgical intervention. If there is IIH, headache is the primary cause, you need to do the VP shunt or LP shunt or serial lumbar punctures to reduce the pressure. That will reduce the headache. But if his vision is threatened, like the previous cases I showed you where the fields are significantly constricted, optic nerve sheath decompression with or without shunt should be done. Remember? Something is popped up here. Remember, ONSD is something we as ophthalmologists can do, and we are the only ones in salvage vision because in IIH, the only and serious complication that a patient can have is completely loss of vision. They can go completely blind. They don't get any other neurosurgical problem. So we should know how to do it. So a quick way how to do, 270 degrees peritomy has to be done. Hook the medial rectus muscle. After you do it, pass sutures through it, isolate it, and then take the baseball stitch. This moves the eye completely laterally. After you move laterally, look at the optic nerve head. You can see here, this is the elevated optic nerve head with the translucent optic nerve head sheath. So this surgery is a medial transconjunctival approach. With a bent keratome, you go into a blood-free area, as you can see, and release the pressure. Note the gush of fluid. This fluid is completely the raised CSF, which is around it. Take a part of it outside, that's the optic nerve sheath fenestration, and break the attachments around. This is followed by a closure by getting the muscle back to its position and completely close the conjunctiva. So you can see in this pre-operative patient who had a vision of 636 in both eyes, with significantly constricted fields, underwent ONSD, and post-operatively you see flat disc and 6x6, and the vision fields completely comes back to normal. And that's the great part of doing an ONSD. You can get back the vision and salvage it as an ophthalmologist. Now, a quick other question of patient with bilateral optic disc edema, a 33-year-old referred by a neurologist to rule out papilloedema, had tinnitus. These patients also can have tinnitus. What interestingly you should note is 612 vision, and there is vitreous cells. So when you look at the disc edema is there, but carefully look at the retina as well. You can see on red free. So red free is a very, very important tool for us to pick up features around the optic disc, and you will see multiple errors of NSDs, that is non-serious detachments, you can see, and PEDs. So important red-free photography, vitreous evaluation, and look beyond the disc. So an OCD showed that there are multiple NSD lesions around it. This patient had VKH. So you need to look not just as a neuro-ophthalmologist at the disc, look at the whole patient, all the aspects of the eye to pick up this. So to summarize, when you have a patient with bilateral disc edema, complete history and a thorough examination is a must. You need to appropriate tests like B-scan, FFA, OCT, BP, blood tests. including CBCSR for identifying the optic neuropathy. You need to do, once optic neuropathy ruled out, do a thorough neuro and neuro-ophthalmological evaluation, that is CT, MRI, MRV, MRA, LP and CSF analysis. You need to rule out papilloedema in all cases. That's a must. Good coordination with the neurologist and neurosurgery is a must. Thank you.
We can take a question till the time we are shifting.
So now the next topic is going to be evaluation in terms of fields, OCTs, B-scan, whatever we can do to isolate optic nerve problems. So I can take questions in the meantime. Yeah. Intracranial hypertension. No, I'll just correct. Benign intracranial hypertension was initially called. It's no longer benign. Now it is either called a pseudotumor cerebral syndromes or IIH.
I have seen neurologists, not to comment on anybody, they give very low dose, half OD or this thing. Patient is uncomfortable, and when we increase the dose, half BD or 1 BD, 1 BD is too much, but 1 OD, 1.5 OD, then patient is quite comfortable. And other treatment they continue it, but why so? And how long we should give Diamox? And they are, when we talk to them, they say that Diamox will damage your kidney, means patient's kidney.
Okay, so this is a good.
But and somebody expert from AIOS, he told ki don't worry for Diamox. Diamox will not damage kidney.
No, that's true. Diamox would damage kidney, but that's also true that neurologists actually don't give much. They start. So ideally, how do you treat patients with IIH? Start with a low dose, and you can increase as high as 4 grams per day. So you can give 4 grams per day. But
how much? That is 250 ka tablet aata hai. How much means?
No, this is how neurologists do give, but you can. But sometimes patients don't tolerate. The amount that can be tolerated is 2 grams per day. You start with about 250 OD and go gradually over. What you need to do is each time as you're increasing the dose, you need to monitor by an ophthalmologist. Now, initially when I started my practice, I had issues with the neurologist, but now that I'm in a health city and I have a rapport with them, they start the Diamox and reduce only when I decide. So ideally, treatment of IIH has to be guided by the ophthalmologist to the neurologist, because what I said, eventually the patient is going to go blind, which is not going to affect them. We are the ones who are going to suffer. So we need to keep on telling the neurologist that, look here, the thing that they're going to lose is vision, so we need to have a good collaboration with them. In fact, the other thing I've noticed is they keep on giving steroids, which is not even indicated. So ideally, they have to gradually increase the dose. Yes, we have to monitor. You need to give supplements with KCL and all so that they don't get side effects of Diamox. But the entire thing can go over about 4 to 6 months. Once you see that the disc edema is resolving, you start tapering it off gradually. Most importantly, put them on weight loss management, which is very, very important. In fact, cutting down the weight can in fact put them on maintenance. That is one of the best things that you can do.
And second thing, I just want, before, just one question. Before we get investigated all, can we start Diamox because patient wants some relief?
No, you have to confirm the diagnosis either by doing an LP to know the opening pressure or B scan to know there's fluid behind. 2 ways to confirm, only then you can label it as IIH.
Thank you.
Okay.
I work in a multi-speciality hospital and we do a lot of transplants and stuff, and we are on regular touch with the nephrologists and neurologists on patients. It's a misconception between ophthalmologists that Diamox damages the kidney. It damages the kidney only if the patients are on renal transplant or are severe diabetes, because it can cause acidosis because of bicarbonate release. In healthy human beings, the kind of dosage we give, ophthalmologists maximum gives 250 milligrams 3 times a day to control IOD and other stuff. It's very, very safe, because some of my patients who are bad glaucoma, operated, shunts, and they have to be on Diamox for a very long time. The nephrologists, and these are the top nephrologists of India, have given a release check for Diamox, and they say that you can do probably a 3-month renal function.